Finally, a reminder that closed captioning for this webinar is available within Zoom, and you can find it using the functions at the bottom of the screen. Next slide, please. So I am Carmen Masson. I'm a faculty member here at the University of California, San Francisco in the Department of Psychiatry and Behavioral Sciences. The I-STARR project is co-led by Drs. Amy Miracle at the Public Health Institute and me. And the team also includes co-investigators Sarah Zemore, Lenny Jason, Mina Subraman, Libo Lee, and our communications specialist Diane Schmidt, and our project coordinator Quinoja Capitini. Next slide, please. So we are also very blessed to have a 17-member advisory board, and they're comprised of a diverse group of leaders in the areas of recovery and recovery housing, treatment providers and payers, our national policy advocates, and researchers and educators. Next slide, please. So let me tell you a little bit about our presenter today, Dr. Bettina Heppner. Dr. Heppner is a professor in psychology at Harvard Medical School and the director of the Health Through Flourishing research program within the psychiatry department at the Massachusetts General Hospital. The overall goal of her research program is to improve access to care for persons seeking to overcome problematic substance use. And her research focuses on recovery support services and how to promote engagement with them, especially outside of formal clinical settings. So without further delay, let's turn the presentation over to Dr. Heppner, her collaborators, and research partners on this topic of the intersection of recovery community centers and recovery housing. Next slide, please.
I'm thrilled to be here with you today. Quick outline of what to expect today. What we are going to be talking about first is to talk about what are recovery community centers, and we'll talk about it in a conceptual way and provide some of our current data on it. And we thought it's important to start there because we do want to talk about the intersection. But before we talk about the intersection between recovery community centers and recovery housing, we want to make sure we paint the right picture and a clear picture of what RCCs are. We then talk about how RCCs intersect with recovery housing. And again, we'll share some data and then provide some in-depth case examples from our community partners, the Detroit Recovery Project, the Pillars, and the Northern Ohio Recovery Association. And finally, we're going to look towards effectiveness testing, which I know is a priority both for this project on recovery housing as well as our project on recovery community centers. So we'll raise some questions and hope to get your feedback on those. Next slide. We will have many speakers today because this is a team effort. We are doing this research together and learning from each other. So I am Bettina Heppner, and I'm an experimental psychologist, and you've already heard lots of other details about me.
I'm Susanna Heppner. I'm a faculty member of the Department of Psychiatry at Massachusetts General Hospital and a co-investigator in this project.
Felicia Pullen. I am a proud member of this team and the founder of the Pillars Recovery Community and Outreach Center in Manhattan.
I am Liv. I am one of the three clinical research coordinators in Bettina's lab.
Hi, everyone. My name is Cora, and I am also a clinical research coordinator here for Bettina's team.
Hi, all. Excited to be here. My name is Allie, and I'm the third clinical research coordinator.
Hi, everyone. I'm Anita Bradley with the Northern Ohio Recovery Association and glad to be a part of the team here today.
Wonderful. You can advance the slide for us. So we'll talk first about what are recovery community centers. Next slide, please. So RCCs, as I call them, which stands for Recovery Community Centers, and they are, I'm having some feedback.
Contact at Lexington for the house over in
Thank you.
Okay.
Perfect. RCCs are peer-run and peer-led brick-and-mortar spaces open to the community. They are filling an important niche in terms of providing long-term support. Clinical services can only provide treatment for days, weeks, and months, and recovery community centers step in to provide long-term support for months, years, decades, lifetimes. They provide and host a whole lot of different things. They provide individualized services to support recovery. They offer a myriad of mutual help groups. They provide access to technology, assistance with basic needs and social services, and very importantly, they host social events. So it's a place you can come to, a physical place you can come to fill a lot of different needs. And any person walking through the doors might have a different need, a different goal, a different reason why they're coming. And the RCCs helps and guides them and supports them in a multitude of ways. RCCs also serve as a central recovery hub for people in or seeking recovery. They are a place for advocacy, for engagement, and they are destigmatizing phase. You can see here the picture of Sika out in the street where people are drawn to it and see, well, what is it? And then learn more about recovery. The guiding principle of recovery community centers is that all pathways are welcome. There's always a multitude of pathways represented there, and the goal is for people to see what fits for me. And RCCs are offering lots of options. Next slide.
So just a little
RCCs,
bit. Oh,
my
sorry.
bad, that's yours, Felicia.
Just a little bit of a history about RCCs, and they grew out of the new recovery advocacy movement back in the late 1990s. And it was in response to an increase of restigmatization and criminalization of people with alcohol and other drug challenges. And there was also some cultural pessimism about the prospects of long-term recovery for people in addiction. And so in around 98, SAMHSA funded recovery programs in its first round of recovery community support programs, which is really exciting. And that was a program that remained active until very recently. Next slide, please.
Science on recovery community centers happened a lot later, 20 years later. And we were very fortunate and excited when NIDA put out a request for applications in 2019 that really focused on peer recovery support services, including recovery community centers and recovery housing and a variety of other things. After 5 projects got funded, and the goal was to bring together multiple key community groups, because only together can we really build a science that is valid and incisive and insightful on peer recovery support services. After all of us got funded, we got together and says, look, we're in this field. It's a new field for science. We want to support each other. So we formed the Consortium on Addiction Recovery Science that you heard about already from Carmen earlier. A little bit later, 3 years later, NIDA put out 2 more RFAs to do more research network building initiatives to really get together the different key stakeholders in designing the science together. And they also started funding planning grants, which are supposed to be projects that allow you to build up towards large-scale randomized trials that can really test the effectiveness of recovery support services. And we'll share data from both of those projects that we have been doing. Next slide. To also put in perspective, this kind of scientific interest is also matched by public health recognition of peer recovery support services. So in 2022, for the first time, you were able to see that peer recovery support services were mentioned in the Office of National Drug Control Policy's plan for the National Drug Control Strategy Plan. And they specifically highlighted recovery community centers, where they pointed out that given the chronic nature of substance use disorder, this extended engagement, which is typically not attainable in treatment, is invaluable. And in 2023, SAMHSA provided very specific guidance on how substance use disorder treatment sites should connect with peer recovery support services. And I believe our own Amy Miracle was chairing TIP64 committees. So thank you. And lots of other people that you know contributed to it. And that really speaks to the discussion and all the dialogue that happens in this seminar series and other places to pool our insights together. And the recommendation is very important. They were talking about that integrating the peer position into substance use disorder treatment programs should supplement peer recovery support services that are offered by recovery community organizations and centers, but they should not replace them. So it's not sufficient to just have a peer working in your treatment center. You really need to connect with the community centers that are out there that are providing a lot more in addition to what you're offering in your clinical services. In 2025, important to note that this commitment to peer recovery support services was reconfirmed in April by the White House in their Statement of Drug Policy Priorities. Next slide. So now we're getting into the data portion of this talk. Next slide.
Yes, so starting with our list of RCCs nationwide. So we developed this list during our first nationwide survey of RCCs that we conducted a couple years ago through our R24 grant. And we developed this list by first contacting all the RCCs that we didn't know about, located in Massachusetts, I-STARR, a couple of other places. And we reached out to them and said, hey, like, you guys know each other really well. Do you guys know anyone else that we're not aware of? And once we got our really big list of 246 total organizations, we then asked them if the definition that's listed on the left of the slide described their center well. And if they said yes, then they made it onto our list of RCCs, which ended up being around 198 organizations that fit our definition, which 122 of which completed the survey that I was referencing. I will note that this list has grown. We are currently at, I believe, 225 active RCCs across the nation. So they are still growing and they are still opening, and that's all very exciting. Next slide. Yeah, so for some of the results of that survey, so we were able to see who these centers were serving. We asked RCC directors to estimate the demographic information of their participants, and through that we were able to identify that about 1 in 5 RCC participants are young adults, and about 1 in 5 RCC participants are Black. This is very important because these are both populations that are oftentimes missed by traditional substance use treatment. So it's very exciting that this novel model of care is able to capture these populations that we otherwise oftentimes miss. Next slide. And then lastly, we were also able to identify some more logistics information about RCCs, and we were able to note that RCCs have a significant number of volunteer staff, which is in line with the peer model of, peers, individuals who go to these RCCs are able to then get involved and give back to the communities that are helping them. And also RCCs see a significant number of traffic. RCCs reported on average seeing about 125 active members per month and about 500 active members per year. So these sites are being used and are integral to their communities, which is very exciting. Next slide.
All right, wonderful. So after learning that, we wanted to ask RCC directors more about the services that RCCs provide. And we had some ideas, but we then asked the RCC directors to indicate if their unique RCC do in fact provide that particular service. And what we found from that is that a majority of recovery community centers provide recovery coaching, they provide social activities, and opportunities to volunteer. So like Liv just mentioned, there's a lot of opportunities to get back involved in the RCC and give back that way. And important to note is that a majority also provide all recovery meetings, really in line with the all pathways to recovery are welcome philosophy that RCCs abide by. These groups are non-denominational. They discuss universal recovery topics, and the one that we're drawing information from is I-STARRs, and they end their meetings with a positive affirmation. So again, really driving home the idea that all pathways are welcome. All right, next slide, please. And then even more, so they, in addition to the ones I just mentioned, provide many other basic needs services. So they provide things such as access to food, clothing, transportation, as well as services such as access to computers for things like job searching or resume creation that is available in-house in the RCCs. Next slide, please. So as you can probably start to get the idea of that there's a a myriad of services available at each RCC, but this is really a result of the RCC design. They really are built with the idea of like multiple purposes. So as you can see here, a majority identify as a social place where people can go and meet and spend time with peers and build a community. They also are a service-oriented place where people can go and use all those services that I was just mentioning. And they also are a great place to get connected with resources and learn more just about recovery in general. And this is in line with SAMHSA's conceptualization of peer recovery support services. It's a bit small, but RCCs do really hit on all four types of support, particularly the affiliational types of support, where people really can come and have that social interaction, that sense of community, and sense of belonging as well. Next slide.
So in our nationwide survey, we were also curious on RCC's directors' attitudes and practices around medications for opioid use disorder. And excitingly, we found that RCCs are extremely accepting and supportive of their clients taking MOUDs, which tends to differ from perspectives that have been previously reported in 12-step facilitation approaches. So we found that 0% of RCCs reported discouraging MOUDs, and 85% of RCCs actively engaged members in conversations about MOUDs. Next slide, please.
All right, next we will turn our attention to the linkages that exist between RCCs and recovery housing. And to set the stage, I just want to clarify some terminology. You've heard you heard the term RCCs, and you've also on one of the previous slides heard RCOs. RCOs are recovery community organizations, and typically they predate RCCs, where an RCO, a recovery community organization, might do a variety of things in terms of advocacy and services they provide. And sometimes they may choose to open a brick and mortar location where people can walk through doors and be greeted by people to receive particular help. But not all RCOs will do RCCs, and some RCOs may operate multiple RCCs. So keep that terminology in mind. Liv already mentioned our list of recovery community centers. There's probably more than we are aware of, and we constantly look for more. So if you know of one, let us know. The list of RCOs, that are also sometimes called peer recovery organizations, can be found on the website for the Center for Addiction Recovery Support. Check out the variety of other kinds of organizations that also exist in this space. Next slide.
So here's some more great news relative to the linkages from OTP directors. Similar to AA, Alcoholics Anonymous, and Narcotics Anonymous, 100% of the clinic directors were familiar with the recovery housing, and 93% provided referrals to them. And this was particularly interesting, especially as we compared it to how many of those directors knew of recovery community centers, RCCs, and that was 80%, and 67%, nearly 67% were providing referrals. So there was less familiarity with the RCCs than there was to recovery housing. Next slide, please. So specific to the RCCs down the street, the question of directors, did you know of the RCC within 9 miles of your center? Only 40% of clinic directors knew about their local RCC, which was 9 miles away. And then relative to the types of interactions, nearly 67% of members had visited the RCC, or actually of their clinical staff had visited the RCC. And then 1 to 15% of the patients, nearly 33%, had been told about the RCC from their clinic, which was within 9 miles of where they were. So this was all really interesting as to not only were they familiar with the RCC, had they visited it, but were they referring their members to the RCC, which was near to them. And then relative to how did the patients hear from the clinic about the RCC, most of those that heard about their local RCC was by recovery coaches. So this again speaks to the importance of having peers working in the RCCs to support members who are coming in. Next slide, please.
So notably, we found that all OTP directors supported the value of and referral to RCCs for their clients, which was really great that they were appreciating the value and seeing that potential in referral. And when asking about barriers to facilitating these referrals of OTP patients to RCCs, most commonly reported was the lack of knowledge around RCCs. OTP directors also worried that RCCs would not be welcoming of MOUDs, which, as previously highlighted by our nationwide survey of RCCs are indeed very welcoming of MOUDs. So again, more knowledge around that aspect. Lastly, logistical concerns were a common reported barrier. So limited staff, time, and financial resources were identified as barriers to making these referrals happen, which could be similar for recovery houses making referrals to RCCs as well. Next slide, please. So wrapping up our summary of data we collected around RCCs, we also wanted to note that the linkage that RCCs provide to other services, particularly recovery housing. So our nationwide survey found that most RCCs, 85%, collaborate closely with recovery housing providers, and many expressed a desire for even stronger connections here. So there's a lot of valuable room for improvement in connecting recovery housing to RCCs. Next slide, please.
So what you're hearing now are some of the differences and similarities about the RCCs and how we work within the recovery housing framework. The pillars is different than NORA, and NORA is different from DRP. So this is a wonderful opportunity to learn about the various ways in which RCCs link people to recovery housing. And so I will speak specifically about the pillars. We do provide linkages to recovery housing, as we do not have recovery housing within our portfolio. And the way that we engage in conversations with participants typically is led by the participants. An individual will come in sometimes after receiving treatment or having been in another program, whether OTP or residential, and they will express the need for housing. We will do one of two things. We will either support them directly with finding and applying for housing, or we will partner with another organization which is right next door, which is Harlem Independent Living Center. And they specifically work with people with disabilities. And I'm doing air quotes. You may not be able to see me do that. But they really have a great connection, not only to developments and housing in New York City, which is extremely difficult to access, but they can often work directly with landlords and other agencies to help move forward housing for individuals in need. And then relative to the advocacy efforts, I mean, this is my favorite part, because advocacy for me is critical to a lot of what we do here, because we do not do many things that you're going to hear from Anita that is done at NORA, but it is the advocacy piece that helps us to move the needle forward. And so, and a great quick example of how we did that is that we, in addition to all of our recovery organizations throughout the state of New York, there are 32 of us, showed up at the Opioid Settlement Funds Board meeting and were able to move the needle from 7.8% allocation of funds in New York to 14.2%, and that happened last Thursday. So it's the advocacy piece that really helps us to support people in ways that we are not able to do on our own, because we are not equipped to do so. And then lastly, the questions are, do we have participants who live in recovery housing units? Absolutely. And we definitely have knowledge of individuals that also work in recovery housing units. But the unique thing about being at the pillars and being around people is that the bar to entry is so low, the threshold is so low that we don't ask many of those questions. I'm privy to understand that we definitely have people that work and live in recovery housing, but none of that is important to us as people are coming in for yoga, meditation, acupuncture, Reiki, workforce development, parenting skills classes. We don't ask a lot of those questions. So it's between that individual and their own recovery pathway. Next slide, please.
And I'll fill in for Angela. Felicia, congratulations. I didn't know about the Thursday thing. That was awesome. Thank you for sharing that. And Felicia raises a great point, which I don't think you've stressed enough in earlier slides. The important piece is that there are many things that RCCs share, but we always note most, but not all RCCs do XYZ, because every single RCC is unique and is designed to fit its community and is designed by the people who are running that particular center. So there's huge variation between each RCC. And that is a strength as well. So Angela for the Detroit Recovery Project also gave us information about how they interact with recovery housing, and they also provide linkages to recovery housing, and they do engage in conversations about housing with participants. So if it could be part of a group, it could be part of recovery coaching that they do, but the conversations about housing are definitely happening at DRP. They also engage in advocacy work with funders and stakeholders to increase recovery housing opportunities for individuals of all ages. And the Detroit Recovery Project also provides housing that is certified by MAR and NAR. They are managed by peers who are licensed by the state as certified peer recovery mentors. They do not require abstinence in their recovery housing. Residents have to participate in the DRP Recovery Community Center activities, and they are given transportation to enable them to do so. Now turning it over to Anita for a more in-depth look at Northern Ohio Recovery Association.
Thanks for sharing. So we're located in the Cleveland, Ohio area, and we have 4 different recovery houses in the city of Cleveland within probably like a 30-40 mile radius. Obviously, housing is important to people in recovery, but particularly the community, a safe, sober community is important when early on. And so we are a recovery community organization, and the different houses that we have, one of them is our treatment program. We do have treatment as well, but the treatment program, usually what happens is the individuals that finish that program, that level of care, which is considered 3.5, very intensive, they're allowed to go to one of the different recovery houses that we have. So we have the first house we opened was in 2017, was called Next Step for Recovery, located on the west side of Cleveland, and we can house up to 18 persons, mothers with their children. And so they're allowed to bring their children with them. We've had little kids in the house, we've had babies in the house, we've had pregnant women in the house. And so we're certified through the Ohio Recovery Housing Network, who is affiliated with the National Association of Recovery Housing. So the criteria and the certification models that particular organization. And so our levels there's 4 levels, 1 which is less intensive and 4 which is more intensive. We selected level 2 and 3, and 2 and 3 is basically the second level. There's not minimal supervision, but we have people on site, mostly like third shift and second shift. The first shift clients that are in recovery are either going to school or they're going to outpatient or aftercare. And then the other level, there are some clinical services that are provided. Next slide. And before I start this slide, so let me talk about the other. So one of the houses we have is for pregnant women. And so the Cuyahoga County Board came to us and asked us to manage this program for them. They actually own the house, but we provide the services. And what I did not know at the time when I agreed to do this is that African-American women and their children and childbirth mortality rate is just very, very high. And you know, there's a lot of things associated with healthcare outcomes. And so keeping these women in a safe, sober environment is increasing the chance of the positive health outcomes for the mothers and the babies. It's so cool that the first time when we first had a mom, she was able to, we gave her a shower here at the center, and actually it was two of them, two moms. And so just to see their faces light up and to have the staff really just kind of love on them and those babies is just a good thing. Our other two houses are men houses for men. I have to say this, I think I see more ladies on here, at least on the screen, but our men's house is a lot quieter. It's a lot more cohesive. And so, but we value both. We decided to build, how many is it? 8 homes, and they're doubles, so 16 units as a result of the need that we see in Cuyahoga County. So 2 of those houses are going to be recovery houses, one for men, one for women, and then we're having it where the families will be able to go into a permanent house. And so, matter of fact, I'm waiting on the city of Cleveland to go ahead and issue my contract so we can get the first 2 up this year, hopefully. But anyway, the motivation for creating housing, again, is just a safe, sober environment. The graph shows the discrepancy between the white and Black population that impacts health and economic disparities as well. This is just the demographics and the individuals that we serve. So if you can see in Cuyahoga County, white people make up more than half of the population, but just over a third of people living in poverty, whereas African American and Black people make up less than a third of the population, but more than half of the poverty. And so, again, we're struggling like a lot of cities around the country with just having affordable, safe housing. And so we're just trying to do our part. Next slide. So here's a picture of the very first house we created, Next Step, where the ladies can stay for 2 years. We had, there was it's called what do they call those? The large churches, mega church. There was a mega church that owned this particular building, and they did not really, they wanted to do the right thing, but because they were a church, they just didn't have the infrastructure. So we bought this building from them, utilized capital dollars from the state. And so over the years, we serve about 60 women, 60 persons per year. Sometimes people come and go, but they can stay up to 2 years. It's female led with female staff, and we can house up to 18 at any time. Residents receive, we work with them to get permanent housing. We help them with employment readiness, with training. We also work with workforce education. We definitely strive abstinence. And again, over the years, I personally have had to look at my personal views around recovery. Where I come from, it was either you're sober or you're not. But over time, now we look at where is that person really in their recovery process. And just because there is a use doesn't necessarily mean that we put them out. We no longer want to be a part of the problem and creating homelessness. We want to be a part of the solution. So I've had to really take a look at that. Not saying that everyone that uses we don't help them to move on. What I'm saying is that we look at ourselves and try to see what we can do different. We refer to treatment as needed. We do provide linkages to childcare and also referral to conferences, to counseling, and different educations like college and places like that, just depending upon where the person is. So that's the very first house that we had. Next slide.
I think that was it. But Anita, before we move on, there was a question from which came first for you, the recovery housing or recovery community center?
The recovery community center, definitely. Yes, and as a need of seeing what the community needs. To be honest with you, we've just been putting one foot in front of the other a little bit at a time, and I have not worked myself out of a job yet.
But you say one little at a time, you've done so much. But I love that too, that it's so clear that what the community needs is you're looking at, well, how do we do this? Who do we mobilize to accomplish this?
Yes.
Beautiful. All right, now from getting from this heartwarming reason why we're all doing this work, I'm going to get more technical for all of us by talking about testing effectiveness. I know that's a big topic for I-STARR as it is for us. We all are asked to build the science to really talk about the effectiveness of peer recovery support services. And if you go to the next slide, a recent summary has shown or has listed 6 different types of peer recovery support services. And this is the same, or these are the same 6 categories that are also part of the NIDA RFAs that funded us and the I-STARR project and so many other great projects. And they distinguish between peer-based recovery support services, which includes recovery coaching and substance use treatment centers, for example, employment support programs, recovery housing, continuing care and recovery checkups that are done after people are finishing their clinical care, and then recovery community centers and recovery support services in education settings like recovery high schools and collegiate recovery programs. And what this review found is that the first 4, which is including recovery housing, there's a good amount of evidence supporting their effectiveness. For the last 2, which only recently the researchers emerged to document them, they have been around for 20 years, but scientists haven't been aware. There is currently not much data. It's lacking effectiveness data, which is why we are all here to collaborate on how to do that science correctly. The complexities in kind of trying to delineate effectiveness are twofold. There's probably more, but highlighting 2 of them is the complexity of intervention, where we have mentioned that RCCs are unique to their communities. They share important pillars, and like, for instance, the openness to multiple pathways of recovery and that it serves multiple purposes. But when you have a complex intervention and each RCC may look very different, how do you compare? Can you conclude all of them in the same? And that's one of our questions for you all, because in recovery housing, you do have very delineated levels where you could potentially do, the effectiveness of level 2 versus level 3 recovery housing approaches. Such delineations don't exist yet for recovery community centers. The other issue is that there's a wide range of potential outcomes. In clinical service, historically, the goal has always been abstinence. As a field, we are moving away from that to recognize that recovery is multifaceted. And certainly the services provided by recovery community centers are multifaceted. At the same time, if you're going to have a clinical, like a randomized clinical trial where we want to demonstrate the effectiveness, we do need to choose a measure. We do need to say, this is where we will see change over time, more so in the people receiving recovery community support services than others. So to answer those kinds of questions, we go to the next slide. We decided to get some help. What we did is we reached out to recovery community directors and we asked them and we said, look, we need to have a measure that is sensitive to change. It needs to be able to measure change over time, and it needs to be validly capturing all the good things that you're doing at the recovery community center, that the things that you do get measured in the outcome measure we choose for any kind of trial that we might do together down the road. We had some ideas. We had some process measures that we wanted people to consider, like client satisfaction questionnaire. Are you satisfied with what you're experiencing at the RCC? As well as a list that we made up about ways in which RCCs confer benefits. It's still something we are working on and towards to be very concrete about the kinds of supports people receive. And then we had more downstream measures that are really measuring outcomes. So you'll probably recognize the BAC-10 here, the brief assessment of recovery capital. We also included a measure of quality of life. We had the substance use recovery evaluator, which is a multifaceted tool. We looked at flourishing. Flourishing is an important piece of recovery. And then just life goals in terms of which ones are you experiencing. I think Ellie put the link already in here. All of these scales and their full items, scoring, all the information you want is on our website. Oh, and then I totally took that away from you. Carry on for next slide.
So the way that we asked them, we didn't make this a multiple choice test for people to know these scales off the bat. We described on different pages what each measure was intended to capture and showed people item by item what they asked and how people would answer them. And then how those would be scored. Like I said, total score, are there categories? How do we use that information? And then at the bottom, we put those 2 questions that Bettina just went over to say, so does that seem like people would make progress on that? And does that make sense for you? So next slide, please. And overall, well, we could say all the measures were successful in terms of people really liked them. They thought they would make progress on them. So there was overwhelming agreement that they are, from quality of life to client satisfaction to flourishing, all those dimensions made sense to people, and they thought that they could make progress on them. Of these measures, we would recommend using the Substance Use Recovery Evaluator, SURE, to use in RCTs. And the reasons why we prefer that, they all did well, so you can't go terribly wrong with them, but this one in particular, it is a multifaceted instrument that covers a lot of the different domains that RCCs target and that are recovery goals. 93% of the RCC directors believed it could capture the progress that people make when coming to their centers. There was a really rigorous and community engaged scale development process where people were asked, like, do these items make sense to you? Is it readable to you? Do you know what we're asking? And they threw out a lot of items that didn't meet those criteria to come up with the best ones. And it also resonated with the academic community who said, well, this is really solidly built and they're using it in RCTs. And the RCC community liked it so much that it is currently being used in routine data collection by 163 RCCs, possibly counting. And there is a seminar as part of our seminar series where you can hear all about it by the scale creator on how this was developed and what it does. Next slide, please.
And I did see your questions. We only have 2 minutes left, so I'll wrap this up and then we'll answer the question I saw in the chat. The other piece, the one complexity was how do we measure it? And then in terms of the complexity of intervention, I did mention this already a little bit, and we're curious to see if you guys feel like a recovery housing is very diverse, or if level 1, 2, and 3, if a houses within those levels look very similar. For RCCs, we can mention that they are usually they are democratically run or run by the peers. So that's similar to what you might see in level 1 and 2 housing. They do have paid staff, but as we point out very early, RCCs also include a lot of volunteer staff, and they're an important lifeblood about how these RCCs function, which is different from recovery housing. And then RCCs are very different across all levels of recovery housing in the sense that they don't do drug testing. That is not something that they do. And that is important to keep in mind. In terms of folks who are clinicians who want to test treatments, keep in mind RCCs cannot be manualized. This is something that lives in the real world where people who are at the centers are creating what is happening at the center. So however we're going to measure the effectiveness has to be flexible to appreciate that. All right, I think if you go to the next slide, all we have left is a big thank you to you all for inviting us and wanting to learn about recovery community centers and how they intersect with recovery housing. We are incredibly grateful to NIDA, who is supporting our work in wonderful ways, just not just by funding, but all kinds of other support as well. We've met and talked and keep interacting with so many RCC directors, staff, and participants who come together to talk with us about these science advancing questions and take our naive questions and give them insightful answers. It's been a wonderful team effort. I linked some further resources here about our own seminar series, which we also already record, so you can go back to previous sessions that we have. And if you go to the next slide, shameless plug, of course, for our next seminar, which is on December 5th on the employment experiences of peer recovery coaches and peer support specialists in Michigan. And you can see in our seminar series, we do bring together a variety of key community groups. And we love the discussions and the thoughts that come from bringing us all together to tackle these issues together. I think,
Great.
Amy, it's over to you, or Carmen.
It's over to me. Thank you so much, Dr. Hepner, your research team, your community partners. So at this point, we wanted to open up the discussion for our audience members to engage in that. And I think there were a couple of questions in the chat. So this is the opportunity for audience members to raise their hands or add additional questions in the chat. I think I did see something earlier, Amy.
Yeah, so there was a comment, more than a question, a comment about that there's too much separation between treatment programs, RCCs, and recovery housing. And there needs to be more collaboration, more working together, more linkages. So I'm really excited that Felicia, you talked about linkages in your presentation. And I wonder if you could just expound upon kind of what exactly that means and how do you develop them?
Sure. I was very fortunate that the beginning of my career, I started out learning what the strategic prevention framework is. And a part of that is having 12 sectors to support the work that you do. And so I've carried that not only through the prevention portion, but through the recovery. Linkages include my local hospital. I can call the chief medical director at any given point in time, and he will either meet one of my people coming in, or he will support in making sure that the correct department gets that link to support the individual. It includes being able to call my local OTP, the outpatient centers. There are many of them here in Harlem, and so I have choices that if someone comes in saying that they want support and want to receive medication for an opioid use disorder, I can call them on the phone. So those linkages are key to helping us do the work that we do. We have free medical appointments because of a linkage with a College of Osteopathic Medicine. And so it's really the linkages that give us the muscle to do the work that we do.
Are those linkages formalized? Do you have MOUs in place? What are the mechanics behind those linkages?
Yeah, predominantly they are formalized, and we do have MOUs, but sometimes it's just having been out in the community and putting my boots to the ground, and I'll run into the director of the Ryan Center, which is in our community, and I'll say, hey, I have plenty of people that could definitely use your support with Hep C, HIV testing. Can I give you a call? And so it's a combination of both. I think, you know, it's important just to know who the people are in the community that can do the things that you cannot. How do you connect with them in a meaningful way, and be fearless enough to pick up the phone and call to say, hey, I need your help.
Other questions? I did see another question there, Amy. Do RCCs intertwine strategic planning in their outcome metrics? Aditi? Oh, go ahead.
I was going to say, I was going to refer to Felicia and Anita to answer that question.
Anita, you want to take that first?
Sure, yeah. I want to say some do and some don't. I think it depends on where they are in the evolution of their organization. Some of us that have been around, you know, for 10, 15 years, I want to say absolutely. I know that we do. It helps us to do a better job to really forecast where we're going. But I also know that being a very new recovery community organization, sometimes it's just a group of people that are meeting in a church basement, and they're meeting on certain days and they're trying to get started. And while they have most wonderful ideas in heart, they may not necessarily have the money for a formalized plan. And I think there's some plans that are formal, but I think there are other plans and great work that's being done across the country that's really just boots on the ground, and it's not necessarily formally documented. They're not there yet, but part of what I see us all doing is to help them to get there.
That's a mic dropper, Anita. I have nothing else to add to that.
Oh, thank you. I'm Aditi, and I am a recipient of one of the I-STARR awards, and I work with community pharmacists, and Amy Miracle is my mentor. And my question, I think, Anita, you might have answered. This is sort of my first time being exposed to this idea about what has community buy-in besides the people that are actually attending, that are actually participating. What has been community just reception, and then what's needed to really just support this program?
That's a great question. So let me start to where we were. Initially, when I started, I was working for the county, which was the funding body. So they were responsible for funding the organizations in Cuyahoga County. I was assigned to 23. I was a consumer, and they asked me to create a consumer advisory council. And in the beginning, it was a lot of tension because the clinical team didn't understand where the recovery peers were going with this. And so there was this, we only have limited money and what's going to happen to our money. So over time, other states, and I will name them, Texas, Pennsylvania, Connecticut, I feel like their state got on board. They started building infrastructure for RCOs, whereas in Ohio, we built the infrastructure within our basements and churches, and then the state got on board. And so, but I want to say across the country now, I'm so pleased to see that like we're even able to have a presentation and workshop like this, and that people are really getting on board. They're really starting to work together. I think we really need more people like you all across this screen to push the envelope, because the work is being done, it's being recognized, and we just have to keep at it. So we've come a very long way to answer your question.
Well done. Thank you.
Do we have time for me to respond to that, Amy? I saw you unmuted.
Yeah, but I do want to get to another question, a couple questions in the chat, but go ahead, Felicia.
Okay, the only thing that I will add to that is that sometimes the community itself gives pushback. And so, for example, what we're experiencing here in New York City, specifically in Harlem, is the impact of gentrification in this community. And so they do not want those people in their community. And with that, there have been responses by funding bodies, agencies that will not give licenses for additional work in a community where the gentrifiers have a louder voice than the people in need.
So Carmen, do you want to address Roland's question? I sense there are changing attitudes about what recovery means. How are you managing that across recovery centers and houses? Anyone want to dive in?
I'll dive in, and I'm hoping that the rest of you guys will correct me if I'm wrong. From my understanding, like when I think about recovery and the definition of it, I think it comes really from these recovery organizations, from recovery community centers and peers and so forth, who taught the field that recovery is a lot more than abstinence. So I think it's the clinical world that is struggling to adapt. But I think within the recovery services, that definition has been much more all-encompassing than it has been in other settings. That's my take on that. What do you all think? Do you guys feel like in your centers, the definition of recovery seems to be changing and you're adapting how you think of recovery and how your peers talk about recovery?
Yeah, so I'll jump in on that. Absolutely. I remember when I was first conceptualizing what this place would look like. It is nothing compared to what it looks like now. And that's because the community is leading this space, and it's a living, breathing entity, and it changes almost monthly. So I could not stand firm on what the recovery definition is, because it is what the people say it is when they come in.
Yeah, I agree with that. Initially, it was total abstinence, and then when we started having harm reduction, we definitions started changing, and now with the new executive orders, things are just changing again. So I think it's going to be a constant evolution, and it's personal for everyone.
Mm-hmm. We have somebody's hand up, Amy. John?
Yes, thank you for a great presentation. Just want to jump in and put a little attention to the political aspect of recovery. Yeah, it's changed a lot, and I think you have to think about the context and an ecological sort of perspective. For example, a friend of mine is with Rain City Housing up in Vancouver, in British Columbia. Their approach to recovery and their approach to harm reduction much different than what we typically do in the States. So I just want to say that it's important to take a look at the context and the political swirls that are involved. I know some counties in the US were basically bailed out by Big Pharma, but mandated to insist on medication-assisted treatment as the standard for inpatient treatment. Other counties are not that way. But I like the openness that people like myself who come from a traditional absence-based approach, showing the flexibility and understanding. Sort of like the old adage, how many psychiatrists does it take to change a light bulb? Only one, but he has to really want to change. And I think that it's this thing where we say, well, that person didn't really want it, or else they would have, jumped these high hurdles we set in front of them. Well, maybe those were unrealistic. And I like the flexibility where maybe we can meet them where they're at, to kind of quote Milton Erickson and his approach to psychotherapy. So it's great to see people who are taking an absence-based approach, showing some flexibility with the use of medications, not kicking people out, but maybe on a case-by-case basis, understanding the context in which the patient is working in. This to me was unheard of 30 years ago. So thank you. It was a wonderful presentation. I enjoyed it very much.
A great comment. Thank you so much. And thank you for all of the questions. I hate to cut off the discussion. It's been really wonderful hearing your questions. Before we leave today, I want to give you a heads up about some other webinars that are coming up in the next couple of months. Next slide, please, Kunoja. So next month's webinar will feature Aaron Williams, who is one of our advisory board members from the National Council for Mental Wellbeing, and he'll be presenting on new horizons and opportunities for recovery housing. And in December, we're going to hear from our own Aditi Tarfa, and she'll be presenting on expanding the impact of pharmacy services by integrating them with recovery housing. So unless otherwise advertised, our webinars occur on the third Tuesday of the month from 11 to 12 for those on the West Coast, and 2 to 3 for those on the East Coast. And you can register for any or all of the webinars scheduled on the I-STARR website. And you can also stay connected with us through our social media accounts, which are listed on the slide here. And while you're on the website, you may also see information about the I-STARR training series. So we do have a training series that is 12 webinars with separate training topics for recovery housing operators and providers, as well as those interested in recovery housing research, and those also who participate in these webinars. You will receive a certificate once you complete the webinars. And you can also be identified on the I-STARR website as somebody who's completed the training. So at this point, the live training series has ended, and we can only track completion of the webinars if you register for the series and view the webinars on the I-STARR Learning Management System. If you have any questions about the training series or how to complete it, you can reach out to us. Next slide, please. So we've run out of time, and I just want to thank Dr. Heppner, her research team, her community partners for such a wonderful presentation. And we hope that you will join us back again on Tuesday, November 18th. We hope you enjoy the rest of your day and the month. Thank you so much for being here with us.